Participate today, and Pravesh, Mike, and I are going to talk about 3 occupational diseases and some work that started about 5 years ago. So I'm going to kind of review the framework, how this got started, and then we'll each talk about one or several diseases. And I just have to see here how hang on. So this is what I need to use? Okay. So I'm going to provide a brief description of the Ontario Occupational Disease Strategy Framework, and then, as I say, we will look at some specific diseases as far as incidence and prevention is concerned. So about 5 years ago, the WSIB, when prevention was still in the WSIB, created a working group to look at occupational disease prevention. The working group produced a product, and then OCOW supported some further work on 4 disease areas. So we basically took the high-level strategy and provided a more detailed framework for those 4 disease areas. And then in this past year, OCOW has supported an update of that work. So this was the original work. Alec and Loris Molinos from Valley were the co-chairs of the working group. Rick DeMills from Workplace Safety North, Renu Callinan from the Ministry of Labor, myself and Alice Peter from the WSIB were the working group members, and we worked away over a number of months and developed the framework. So this is a summary slide of the framework. The vision was the elimination of occupational disease in Ontario, and there were 6 key strategic objectives outlined. So what I'm going to do when I go through my presentation on skin disease, I will come back and use each of those strategic objectives and kind of fill them in from the perspective of skin disease. So as I say, OCOW supported the development of much more detailed plans, and in April this past year, Irina Kudla and I, Irina's here, updated the plan on occupational skin disease. So what is occupational skin disease? The most common type of occupational skin disease is contact dermatitis, and in fact in the plan it's dermatitis that is actually specifically mentioned. I want to point out another important group of occupational skin disease are in fact skin cancers. I think these are being increasingly recognized, and today we have Thomas Tenkat here from Ryerson who will be talking, I think, specifically about some of those issues. Certainly in Europe, those interested in occupational skin disease are starting to talk a lot more about occupational skin disease. So I think this is the growing kind of second major focus in the skin disease area. There are a number of other skin diseases related to workplace exposures, but that's not the focus of today. So the brief, quick overview: irritant contact dermatitis is the more common type of contact dermatitis. It's about 75%. This is a worker that has fairly acute irritant contact dermatitis. The causes are ubiquitous. The most frequent cause is wet work, which is typically defined as either wearing gloves or having your skin in water or fluids for more than 2 hours a day. But there are a variety of other common workplace exposures that may also cause irritant contact dermatitis. Cleansers, detergents, things that are alkali or acid, oils, greases, cutting fluids, solvents, some plants and animals, and fiberglass. So if you can think of the variety of types of workplaces across the province, you'll see that for a number of them, at least one of these agents will be an exposure of workers. There's also allergic contact dermatitis, which accounts for about 25% of contact dermatitis. Again, this is an individual who has allergic contact dermatitis related to glove use and an actual allergy to one of the components of the glove. So common allergens in the workplace that cause allergic contact dermatitis: rubber components, commonly found in gloves that workers wear as protection, preservatives that are used in biocides and cleaners. From a metal perspective, chromium is probably the most common work-related contact allergen, although nickel is the most common in the general population. And then a variety of resin systems, so epoxy resins, acrylates, and formaldehyde are also fairly common causes of allergic contact dermatitis. So now moving on to incidence and prevalence, and this is a constant theme around occupational disease. Occupational disease is under-recognized, and even if it's recognized, it's often underreported. So it's actually very challenging to get really good information about incidence and prevalence. So I'm going to present you just a little bit of a snapshot. So Europe is probably our best source of data. In most European countries, occupational skin disease is in fact the most common occupational disease. It's about 33% if you look at their pooled resources. And several studies from Europe suggest that the actual number of cases is between about 5 and 100 per 100,000 workers. But again, you have to remember, even though reporting may be better in Europe, there's still significant under-recognition and under-reporting. In the United States, we can look at Bureau of Labor Statistics. And again, what's kind of the interesting piece here is when they looked at their reporting of occupational disease, of the common ones we think about, skin disease was in fact the most common. It was about 17% of occupational illness. Hearing was 12%, and respiratory conditions 8.5%. So bottom line is, in the group of occupational diseases, skin disease is typically the most common or one of the most common occupational diseases. If we look at workplace-based studies, which are actually much more likely to give us a real sense of what's actually going on, there are not a lot of workplace studies because they're expensive, they're resource intensive, but there have been a number done in two sectors in particular, hairdressing and healthcare. So if you look at the more recent studies looking at prevalence of skin problems in hairdressers, the prevalence in populations runs between 35 and 45%, so very high. And hairdressers have exposure, first of all, to wet work, and they also have exposure to a number of allergens. But the other sector is the healthcare sector. And again, there have been a number of recent studies from Europe, from Southeast Asia, and the prevalence is about 20 to 25%. A recent study looking at student nurses, and again, the prevalence of problems over their 3 years of training. In the first year of training, 23% had hand dermatitis. That increased to 25% in the second year and was up to 31% by their third year of training. And probably the most disturbing number of all is a recent study that Catherine Nichol and I did where we looked at healthcare workers in Ontario, and we found in that group that 72% had changes consistent with hand dermatitis, 13% had moderate to severe changes. So a very, very common problem, certainly in healthcare. So that's when you actually go out in the workplace and actually see people, question people, examine people. But the problem is, as I say, we actually have very little information like that. So typically we use our compensation statistics to get our information about skin disease and other occupational diseases. So this is some information I got from the WSIB. I was doing a presentation at PSHSA a few years ago. Henry, thank you for making the connections. So between 2008 and 2012 in the healthcare sector, there were 400 claims. So over 5 years, 400 claims submitted, both lost time and no lost time claims. So that's about 80 claims a year. So this is what I call the numbers disconnect. So I've made some assumptions. You can question the assumptions, but I think it gives you a sense of the magnitude of difference between compensation claims and potential actual prevalence and incidence of disease. So the healthcare literature suggests about 25% prevalence in healthcare workers. If we look at the study we did very recently and take only those with moderate to severe disease, that was 13% of the group we looked at, and let's assume that only 50% of those are related to work specifically, although in reality it's probably higher. So that would give us a prevalence of about 6.5 to 12.5%. The College of Nurses reports that there are 150,000 nurses registered in Ontario, so let's assume 2/3 of those are working, just for ease of calculations. That's about 100,000 nurses in the province. So if we take the prevalence numbers we have from workplace studies, apply it to that 100,000 nurses, that would give us about 65 to 12,500 cases if we actually went into workplaces today and looked. And yet we have 80 claims filed a year. So this is just to say that relying on compensation statistics, particularly in the area of occupational disease, is very problematic. And just gives us the sense of magnitude. It's not just like we're missing a few cases, we're missing by far the majority of cases. So that's my comment around prevalence and incidence. And the reality is we could apply that, I think, to virtually any occupational disease we talk about. The burden of occupational disease, so you may say, and people often say, well, like it's just a bit of skin disease, it's just a bit of a rash, who cares? Well, the problem is people that have it care and others care. Certainly a number of individuals, even though they get treated, have ongoing disease. There is actually significant functional challenges in a number of people. If you have fairly significant dermatitis, basic things like bending your fingers, making a fist actually are very challenging. So actually in a study we did, individuals with hand dermatitis actually have decreased hand function. So if you're doing manual work, that's actually going to impact your work. There are obviously quality of life impacts, and equally in the studies we've done looking at workers after they've been seen and diagnosed, a significant proportion, 25%, 30%, have either job change or job loss because of their skin disease. So it matters. Not only is it common, but it also has a substantial effect. So what about prevention? So as I say, what I'm going to do is use the prevention framework that we came up with 5 years ago. There are 6 strategies. So I'm going to talk for each strategy, kind of what you would do in the case of skin disease prevention, and then talk about the strategy, what we suggested, and where we are. So the first strategy was focus on reducing harmful exposures, fundamental principle, occupational health. So in the case of skin disease, that might be elimination or substitution. The classic example that I think most of us know about, when the latex problem was identified 20 or so years ago, we changed from latex gloves to non-latex gloves, powdered gloves to non-powdered gloves. And we certainly saw a decrease in disease. And Gary Liss and Susan Tarlow did a lot of work around that, so we have good evidence for that. There's also good evidence for a variety of other things. And the thing that if I said, what could we do in Ontario? Chromate is used in cements in Ontario, Canada. Chrome is a significant contact allergen. We see construction workers who have incredibly severe disease related to allergic contact dermatitis from chrome. A number of jurisdictions across the world, Singapore and a number of European jurisdictions, have actually eliminated chromate from cement. And guess what? Their prevalence of allergic contact dermatitis to chromate and the number of workers that have chromate sensitivity has decreased. They've actually demonstrated that in several, again, very good studies. So there's kind of something that's just waiting. We've got good evidence it works. So if we had the regulatory desire to do something, there would be something one could do that certainly would impact the construction sector. And also the elimination of a number of aldehyde disinfectants. So there are some very good examples about how elimination or substitution can work. There are a variety of no-touch techniques one can use. Personal protective equipment is a strategy that's probably most commonly used to protect the skin. The reminder, though, that gloves contain allergens, and wearing gloves for more than 2 hours a day is wet work. So gloves often cause the problem rather than protecting the skin. There are administrative strategies like time restrictions and rotation of jobs, skin protection using various kind of appropriate cleansers, moisturizing creams are important, education and training, and enforcement. So what did the strategy suggest? So what I've done, it's October, so I've used pumpkin color. So I really tried, and I'm glad it shows up. I was worried that like it gets on a different screen and it's not going to be there. Anyway, so I've noted the strategies, what we've suggested, and the ones that are in pumpkin color are the ones where I think we actually have done some work and have started to actually put the strategy into effect. So short-term strategies, reducing exposures. So there is a fair bit of regulatory work around skin exposure. NIOSH has a skin notation methodology, and again, we felt that it would be appropriate at a regulatory level to actually look at that, see if we are using that in Ontario. We have done reviews of the programs in place in other jurisdictions. The chromate is an example. We've reviewed the regulations in other jurisdictions. So Germany actually has a regulation around wet work. Has a definition of wet work, and it has a regulation for workplaces around how to prevent or reduce exposure to wet work. So there's, again, something, if we were interested, it exists. And we've also been collecting and reviewing available resources. The medium-term strategies deliver educational materials to the health and safety associations. And again, we've done that. We have poster sets, which we've developed with Workplace Safety and Prevention Services. We have an e-learning module, which was done with Public Services Health and Safety Association. And we also have another very, to me, exciting group. We have a working group that's working on fact sheets for skin disease. That working group has representatives from the 4 sector-based HSAs, from OCAL, from OCRC, and the Ministry of Labor, and we're working collaboratively to come up with core content that we all agree on. So each group isn't producing its own, but the idea will be we'll agree on the core content, and then each group will customize it for their particular sectors and groups. Delivering educational materials to the Ministry of Labor inspectors is still a thing to be accomplished. And then again, if the NIOSH skin notations are felt to be useful, could they actually be implemented in Ontario? Second strategy, establish appropriate reporting and surveillance mechanisms. So for skin disease, again, as for many of the non-malignant occupational diseases, early identification, diagnosis, and appropriate management is a key factor in improving outcomes. So the earlier you make the diagnosis and implement treatment, the better the outcome. So in fact, systems for screening and surveillance are actually of critical importance, not only for us to understand what's happening, but equally for the individual worker to improve their outcome. So short-term strategies: collect and review available surveillance and screening tools, review the experience in other countries. And that, again, we've been doing. So the results I presented from the work that Catherine Nichol and I have been doing, that was one of the early attempts at the screening tool. We now have a very large feasibility study going on actually using the tool, both as a tool used by the occupational health nurses, but also as a self-screening tool, so workers themselves can self-screen. And finally, at St. Mike's, we patch test a large number of people each year, about 500. We have a research database where we collect information not only on the diagnosis and what individuals reacted to on patch testing, so what allergens they were positive to and were causative agents, but we also, as part of that, collect information on the workers' reporting of prevention in the workplace. We've almost finished 4 years of data collection, so we have about 2,000 workers in that database. So that will provide, over time, very interesting tracking information. First of all, what allergens are decreasing or increasing, but also it's just a kind of snapshot again of what workers are reporting about what prevention training they're actually getting in the workplace. Medium stage, develop a tool to assess exposure to wet work. As I say, it's probably the most ubiquitous and common exposure when we think about contact dermatitis. As I say, we're now in the midst of the screening study and continuing the database. Long-term, convene a process to consider the use of screening and surveillance more broadly. Hopefully, eventually, CAREX will include exposures that may not relate specifically to cancers, but might also relate to skin exposure, and continue the patch test database. Third strategy, ensure maximum use of best evidence. There is a rich literature in Europe related to prevention programs, and I think growing evidence from Ontario and our own experience about what works and doesn't work as far as prevention is concerned. Short term, continue the linkages with system partners, which I've just described an example of that. Continue to support research in the area, so that's going on. And long-term, work with the Ministry of Health and Long-Term Care at instilling the occupational history in the electronic medical record. And I didn't put this as orange. It's kind of a quasi-orange because, again, we have a large study going on with OCRC and CREOD and OCAL, where we're actually testing the use of occupational history in community health centers across the province. So we finished the first site, learned a lot from that site, and we're now moving on to the second site in Val's area. So hopefully in another 2 years maybe, we will have good evidence to help convince the ministry about including the occupational history. Fourth strategy, improve education and awareness. There is no question awareness is low. Work we've done looking at health and safety associations, their frontline consultants generally think that their information and kind of knowledge is not particularly strong, and certainly their view is that their clients' awareness tends to be low. There have been a number of national campaigns in Europe to actually promote skin health, in Germany in particular, but also in the United Kingdom and Australia. Those jurisdictions also have guidelines around wet work. So I think, again, we've got opportunity targeting high-risk sectors, encouraging skin exposure assessment, skin protection and prevention, for professional training for health and safety professionals, both in their initial training and also in continuing education, and to review models in other jurisdictions, which we've done. Medium term, review the approach to dermal exposure assessment used by the Ministry of Labor and look at legislative opportunities. And then in the long term, actually develop a guideline, a regulation related to wet work, as I say, as the most common exposure. Target high priority diseases, exposures, and industries. I think I've shown you contact dermatitis is common. The common exposure is wet work, and the key sectors are the service sector, the healthcare sector, manufacturing, including the auto manufacturing sector, and construction. So it cuts across a number of large sectors in the province. Short term, trying to help the health and safety associations to focus educational and training programs on their high-risk industries, and equally in the longer term, work with the Ministry of Labor to make sure that these are included in some of the blitzes in high-risk industries. Final strategy, promote ongoing engagement and strategic partnerships, a working group of key stakeholders. So as George said, this is hopefully the start of that today. We have it happening in particular areas, but I think we need it broadly across the board. Hopefully that working group will come together. It'll address legislative initiatives as well as practical initiatives, and hopefully in the longer term, we will actually have an appropriate mix of actual prevention in the workplace plus the regulatory support for that activity. So in summary, occupational dermatitis is common. It's caused by common exposures. We have a strategy developed which is in part implemented. A lot of the resources around skin disease are on the CREOD website in a part called the Skin Health Toolbox. We need to continue to grow our partnerships at the strategic level, so such as today, but also at that practical level. So the working group that's working on the fact sheets, to me, is a very practical example of us working together. And that's just the website address for the Skin Health Toolbox.